This is a short video on growths, neoplasms, and cancers of the skin. Throughout this video, we're going to be talking about the diseases listed on the left. We're going to be differentiating between harmless growths and benign and malignant neoplasms that occur on the skin. Let's begin with angioma. Angiomas are also called cherry angiomas. Angiomas present as red papules. They often occur in patients over 30 years old, often on the trunk. They're harmless, but they do not go away. When traumatized, an angioma might bleed or clot, and they can often darken in color. Infantile hemangiomas are a subtype of angiomas. These happen in infants, and they are a proliferation of endothelial tissue. They can result in a red or a deep blue-purple nodule. So if it's red, it's a superficial nodule where you see the blood more clearly. If it's a blue-purple deep nodule, that's further down and in the deeper layers of the skin. And of course, infantile hemangiomas, as the name implies, are common in infants. They grow for about 1/2 to 2 years before involuting and usually going away. You can treat infantile hemangiomas with beta blockers, propranolol specifically, if they are large and disfiguring, but otherwise treatment is not necessary. Acrochordons, also known as skin tags, are next. These are fleshy growths of skin with blood supply. They have their own blood supply, and they can be skin-colored or brown. This is a picture of a acrochordion. These are common in the armpit, the groin, the eyes, or the neck. These can be a marker for insulin resistance. The risk factors for skin tags are obesity, friction on the skin, and simply having the genetics for it could give you a high rate of skin tags. Treatment is not necessary for skin tags, but they can be snipped or frozen if you cosmetically desire it. Next is seborrheic keratosis. These are benign superficial growths. They're common after 30 years old. They can occur on any parts of the skin except for the soles and the palms. They often occur in multiples. There's often not just one. There's often more than one SK. These do not go away, but they're also harmless. They're often dark and pigmented, but they can also be tan and hypopigmented, especially on people with darker skin. They have a characteristic stuck-on appearance, and they sometimes look waxy or oily. Stuck-on means that it doesn't really look like it's connected with the rest of the skin. It looks like it's a sticker that you could just peel off. The treatment for seborrheic keratosis is not necessary, but they can be frozen, electrodesiccated, or curetted for cosmetic reasons. This often reveals a pink base underneath the stuck-on seborrheic keratosis, and that pink base would be like a permanent stain. Many SKs appearing out of nowhere or seemingly out of nowhere can be indicative of a GI cancer, of a gastric cancer, and that's known as the lesser Trelot sign. There's also a condition called dermatosis papulosa nigra, which is when you have many small seborrheic keratoses. Stuchokeratosis is another condition in which you have small SK on the ankles and dorsal foot, and those SKs might have a white grayish color. Next up is lipoma. Lipoma is a benign tumor of fat tissue. They present as a soft, movable, rubbery lump underneath the skin. They're subcutaneous in location. They can often appear multiply. You can get more than one lipoma. They can be familial and sometimes tender. Treatment of lipomas is not necessary, but they can be surgically excised. These three are all kind of similar: sebaceous hyperplasia, epidermal inclusion cyst, and pilar cyst. Sebaceous hyperplasia is a skin-colored, umbilicated small papule, often on the forehead and face. These result from overgrowth of the sebaceous gland, and they have a yellow tint from the oily sebum that would come out of the sebaceous gland. It's not necessary to treat sebaceous hyperplasias, but you can remove them for cosmetic reasons. It's important to differentiate sebaceous hyperplasia from basal cell carcinoma. One way to differentiate them is that sebaceous hyperplasia usually come up together with many other sebaceous hyperplasias. There's usually multiple lesions. Sebaceous hyperplasia does not scab or bleed like basal cell carcinoma would. Basal cell carcinoma tends to be translucent, whereas sebaceous hyperplasia has a yellow tint, and basal cell carcinoma also has telangiectasia, which is not seen in sebaceous hyperplasia. Epidermal inclusion cyst is another lesion. This is a benign cyst usually found on the skin. It's made of thin layers of squamous epithelium. This is caused by implantation of the epidermis into the dermis, often from trauma. This trauma can then lead to debris like dead skin and oil being collected within the cyst, which can produce a foul-smelling white residue, which isn't exactly pus. It's a collection of keratin and dead skin and oil, but it has a foul smell. This is an EIC here, often arising from trauma. In this case, it seems like it's an earlobe that was pierced that created an epidermal inclusion cyst. Treatment for EICs are not required, but when they rupture, they may require drainage or incision and drainage for cosmetic reasons. The EICs tend to be sterile and don't require antibiotics. A milium is like a small, tiny epidermal inclusion cyst. These are also called milk spots or oil seeds. They are clogged eccrine ducts, which are just sweat glands that form a keratin-filled cyst just under the dermis. And so they're essentially tiny EICs, and these are examples of milium on the eyelid. Just tiny little collections of dense skin cells and keratin. On children, these milium go away on their own. On adults, they tend to persist. The larger variant of a cyst is the pilar cyst. These are cysts that forms from a hair follicle, often on the scalp. Treatment for pilar cyst is to excise them. You cut them open, you dissect out the cyst, and then you have to sew it shut, probably with a couple stitches. Pilar cysts are larger and tend to appear on the head, and these are most often excised because of their large appearance. And once you pull it out, you can pull the entire cyst out by itself and kind of see that collection of fluid that was where the hair follicle was. Dermatofibroma is another condition. It's a firm scar-like growth with peripheral rim of hyperpigmentation. It's benign, and the dimple sign is one way to differentiate it. When you pinch down on the skin next to a dermatofibroma, you'll notice that the lesion kind of pinches down as if it's anchored to the lower skin layers. Dermatofibroma results from a spindle cell proliferation, often induced by trauma. And here's another slightly unrelated condition, the keloid, which is also fibrous. That's the reason that all of these are on the same slide. They're all fibrous in origin. The keloid is like an overgrowth of a scar, and we're going to be comparing it to a hypertrophic scar. So the keloid is like a worse hypertrophic scar. It's when scar tissue expands past the original site of the injury, past the boundaries of the injury. So this is an example of a keloid. You can see how the scar has kind of grown out further from the original injury in comparison to this hypertrophic scar, where the scar tissue grew more than it should have, but did not surpass the boundaries of the original injury. Keloids are more common in African Americans, often on the earlobes and in the upper trunk. Keloids have disorganized collagen organization versus hypertrophic scars, which retain that parallel collagen. The treatment for keloids are steroid injection. You want to inject steroid into the lesion. You do not want to resect this keloid because it will regrow and often grows back worse than the original lesion. Another way to differentiate these is, the main way to differentiate these is that the keloid exceeds the borders of the original injury, whereas the hypertrophic scar does not. Next up is a solar lentigo. This is pretty simple. It's also called a sunspot, an age spot, or a liver spot. It's a brown macule, can be single or numerous. We see a single one on this arm. This comes from UV damage, often to skin that was exposed to sun. So although this isn't cancerous or dangerous, it's completely benign, it is an indicator of UV exposure, which can be dangerous in itself. Patients with solar lentigines are at high risk for skin cancers, as we just said. There's no treatment necessary for these, but you should encourage patients to protect themselves from the sun because these are indicative of sun exposure or UV exposure. Basal cell carcinoma. This is one of the three types of skin cancer that we're going to be talking about. Basal cell carcinoma, squamous cell carcinoma, and melanoma. So basal cell carcinoma is the most common kind of skin cancer. It's common in the head and neck regions. The classic description is a pearly pink nodule, kind of how you see on that picture there. But this description can, of course, vary, and BCCs can, of course, vary. And we'll be talking about that in morphologies. Risk factors for basal cell carcinomas are sun exposure, having fair skin, and the condition xeroderma pigmentosum. You can diagnose basal cell carcinomas with a shave biopsy, and you should do that before you excise them. Basal cell carcinoma originates from keratinocytes, specifically in the basal layer of the epidermis, and this essentially results from UV light damaging the DNA of the keratinocytes in the basal layer. One notable UV-induced mutation is in the PTCH gene, which is a tumor suppressor gene. So when you have a loss of function of the PTCH gene, it can cause basal cell carcinoma. There are various morphologies, as we mentioned earlier. There's a nodular morphology, which is kind of what you see in this picture here. It's a pearly papule/nodule, often with telangiectasias, which you can kind of see there, those errant blood vessels. And they're often on the face, head, and neck. There's a superficial morphology, which has a pink translucent color, often on telangiectasias, and a patch or a thin plaque. This is more nodular than superficial. Superficial wouldn't be as thick, wouldn't be popping out as much. You can also have pigmented BCCs that resemble melanoma. They could be ulcerated, or you can have any combination of all these morphologies. Treatment for BCC is to curette and desiccate the lesion. You can also do cryosurgery or just excise it completely. MMS is another variant of surgery to remove that. There are non-surgical alternatives. This is imiquimod, 5-FU, creams, and radiation. Back to MMS, Mohs microscopic surgery. This is when you do a histologic analysis of the tumor margins during surgery for maximal tissue conservation. So you scrape out as much tissue as you can see. You look under the microscope to see where the tumor actually still existed, and you would go back and scrape some more and keep going back and scraping some more until you get 100% of the margins, until you clear all of the margins. This is often used for basal cell carcinomas on the face, where you want to preserve as much tissue, as much healthy tissue as possible. Basal cell carcinomas are locally invasive, but the metastasis is very rare. It's very low risk for spreading to other parts of the body. Next, we're going to be talking about actinic keratosis, which is a precursor to squamous cell carcinoma. So we're going to put both of those on the same slide. Actinic keratosis is in that picture up there. It's a scaly plaque, often on the forehead or face, with a rough, gritty texture on touch. It's pre-malignant, and it can sometimes progress to squamous cell carcinoma. That should be an S right there. It can sometimes progress to squamous cell carcinoma. Risk factors for AKs include fair skin, age, genetics and family history, immunosuppression, and sun-exposed areas, often the forehead, sometimes the scalp even. When they're on the lip, they're called actinic kelosis. The treatment for AKs is that if they're single, if there's only one, you can use liquid nitrogen as cryotherapy. If there's a lot of AKs, you want to use a topical 5-FU cream and a imiquimod cream or photodynamics to clear them all at the same time. And of course, AKs can lead to squamous cell carcinoma, so we're going to be talking about those. Squamous cell carcinoma is more prevalent in fair skin that has been exposed to sun. There's a higher mortality rate for SCC compared to BCC, but SCC has a lower mortality rate than melanoma. So kind of talking about the cancers in order of severity, in orders of mortality rate. The rate of metastasis for SCC to the lymph nodes is about 5%. They originate in the keratinocytes, just like the basal cell carcinomas. One notable UV-induced mutation in SCC is P53, which is another tumor suppressor gene. So again, if you have a loss of function in P53, that could lead to squamous cell carcinoma. Risk factors are similar: sun exposure, fair skin, xeroderma pigmentosum, also arsenic poisoning here. There are a few morphologies for squamous cell carcinoma. They can be scaly. They can have a pink, red, or skin color. They can be plaques, papules, or nodules. They can be exophytic or indurated. They could have horn-like appearances. They could be friable, and they could be itchy or pruritic. Here's an example of an SCC that kind of combines several of those morphologies. An SCC in situ is known as Bowen's disease. It often has a circumscribed patch or scaly, rough surface. If it's confined to the epidermis, the Bowen's disease is confined to the epidermis. When it spreads to involve the dermis, then it's called invasive squamous cell carcinoma. Treatment for squamous cell carcinoma is excision and curettage. You can also desiccate it or do that same Mohs microscopic surgery here. Alternatively, you can also do radiation or 5-FU creams, just like in basal cell carcinoma. Next, we're going to be talking about nevi, or the common mole, and lastly, we'll talk about melanoma at the end. So nevi, or moles, can be broken down into congenital nevi and acquired nevi. We're going to be talking about both of those. Congenital nevi, also known as a congenital nevus, congenital mole, they are melanotic nevi starting at birth. They're often dome-shaped, especially on the face. That's like that right there is a congenital nevi. Sometimes they're mammillated. Sometimes they have increased hair density or coarseness. So the hairs coming out of moles can be thick, or the hairs coming out of moles can be numerous. For small and medium congenital size nevi, up to 20 centimeters in diameter, the risk of melanoma is pretty low. There's no risk increase for congenital nevi. Changes in these nevi, however, must be evaluated. You should keep a close watch on them, and if there's any changes, you should report that. For giant nevi, that's nevi greater than 20 centimeters, the risk of melanoma is higher. You do want to refer to a dermatologist in this case. Treatment for small or medium nevi are that they essentially don't need to be treated unless you see a change, or unless they look suspicious, unless they evolve to become suspicious. So they could be shaved or excised for cosmetic reasons, but otherwise there's no reason to treat them. Acquired nevi, on the other hand, are nevi that are melanocytic growths that are acquired after birth. These usually appear before age 20, and they're more common in sun-exposed areas. Over time, the nevi might change from brown macules and papules to pink or skin-colored papules, while the diameter stays constant. So over time, as this child ages, you might expect this brown papule to kind of lighten in color to become pink or skin-colored, but the diameter should stay the same. It should not grow. Acquired nevi are important to be evaluated based on different morphologies from other moles on that patient. So if somebody comes in with several moles like this, and one of them looks way different than the rest, that's something that should be evaluated. That's something that might be more suspicious of melanoma. You can use the ABCDEs for evaluating acquired nevi. This is asymmetry, evaluating the borders, evaluating the color, the diameter, and being suspicious of evolving moles. Those are all irregularities, and any of those are indicative of melanoma. And finally, dysplastic nevus syndrome. This is essentially a condition in which you have an unusual amount of abnormal nevi, and there's an increased risk for multiple inherited melanomas here. This is usually, the cutoff here is usually 50, at least 50 unusual nevi, and it usually appears near puberty, but you can also get these into old age. This is an example of somebody with dysplastic nevus syndrome with several abnormal appearing nevi. There's a higher risk of developing melanoma from atypical moles or normal skin for these people, and it's important to biopsy whenever melanoma might be suspected. It's not practical to remove all atypical nevi in people with dysplastic nevus syndrome, so it is important for them to keep an eye on their moles, to pick out the ones that look different or different from the rest, or are otherwise abnormally evolving. And lastly, we have melanoma, also called malignant melanoma. This is a cancer that develops from pigment-containing melanocytes, most commonly in the epidermis, but also in the mouth, intestines, or the eye. It's usually presenting asymptomatically. Usually patients don't feel anything, don't feel pain. They just see pigmented papules, plaques, or nodules on their skin. And of course, any of the ABCDEs that we talked about earlier can be indicative of melanoma, and the patients often report the change or the evolution of moles that leads to the diagnosis of melanoma. Melanomas can also crust, bleed, or erode, and that's pretty suspicious. So melanomas can exist, can come out of nowhere. They can be de novo mutations, or they can also come from pre-existing nevi. Usually they appear in sun-exposed areas. They originate in the melanocytes, that's the cell of origin. The etiology is that exposure to UVA, UVB, but also UVA to a lesser degree, from prolonged or cumulative sun exposure can create a melanoma, but melanomas can also be sporadic, usually from UVA, UVB, but they can also be sporadic. All ages are affected with melanoma, and the lifetime risk has increased over time. Risk factors for melanoma include immunosuppression, personal family histories, UV exposure, use of tanning booths, fair skin, fair hair, fair eyes, old age, and having many acquired nevi. Some genes that are pretty notable for mutations that result in melanoma are CDKN2A, CDK4, P53, and the BRCA2. The most important prognostic factor for somebody with melanoma is the depth or thickness of the melanoma, also called the Breslow depth. This is the measurement of the melanoma down to the deepest part of the tumor. And of course, a deeper tumor or a tumor that kind of invades deeper has a worse prognosis, has a higher mortality. There are high cure rates for melanoma when detected early. Several subtypes of melanoma. The one with a better prognosis is superficial melanoma, which spreads horizontally rather than down. This is thankfully the most common type of melanoma, and as we said earlier, because it spreads horizontally, it'll have a low depth and thus a good prognosis. Lentigo maligna is another type of melanoma that has a primarily slow horizontal spread. It occurs on sun-damaged skin and in elderly people, so also decent prognosis. Nodular is the one with the poor prognosis. It has rapid vertical growth. It's a nodule that goes down as opposed to horizontally, and that's worse. That's a higher mortality. Acrolentigenous is common in people with darker skin, so the diagnosis is often delayed in acrolentigenous. Amelanotic is kind of tricky because it has a variable appearance. It's not necessarily dark, and it's often confused with other skin conditions, so it's much harder to diagnose. Treatment for melanomas are surgical excision. You might do a biopsy first, but definitely surgical excision. Ipilimumab, which is an anti-CTLA4 monoclonal antibody, and that would stimulate the immune reaction against melanomas. You can use BRAF inhibitors, and you also want to follow up with patients who have had melanomas for life, and of course encourage skin protection for life. So these are pictures of 4 melanomas and kind of the lesions that they came out of. Some of these look suspect, some of these look like other lesions that you wouldn't think would become melanoma, but they all kind of evolved to melanoma, starting with these lesions here and evolving into these melanoma lesions. This has been a video on abnormal growths and benign and malignant tumors of the skin. I hope it was helpful, and thank you for listening.